Well, thank you so much for having us. We're excited to be part of the Ideagen Summit today. My name is Gene Accius, and I'm the Senior Vice President of Global Thought Leadership at AARP. Through our department, we are charged with challenging outdated systems, really kind of thinking about new ideas and how we drive the marketplace, and inspiring bold solutions to shift the paradigm so that all can actually live a longer and healthier life. As we have seen, COVID 19 is a crisis that has spread throughout the world. Early data, broken down by race and ethnicity, shows an alarming picture that the way that this virus is spreading, even within a country, it's not actually equal. Now, there's a range of factors that could explain this, from discrimination to language, that's affecting different groups in different ways. This panel that we will be speaking to today will explore the social, the political, the economic structures that shape how different people experience this pandemic, and what innovative solutions that in the future, a factor like an individual's race or ethnicity will have less impact on their likelihood to live. With me, I'm excited to introduce Dr. Cynthia Bullock, who is the Deputy Challenge Director for Healthy Aging at the UK Research and Innovation. Cynthia leads the innovation activities across the UK government's £98 million Healthy Aging Challenge, supporting the development and delivery of products and services that will allow people to remain active, productive, and independent, and socially connected across generations for as long as possible. We also have Robert Espinoza, who is the Vice President of Policy at PHI here within the United States, where he oversees the Policy, Advocacy, Research, and Public Education Division. Robert is a nationally renowned expert and featured speaker, both in terms of the issues on aging and long-term care. We also have with us George MacGinnis, who is the Challenge Director, also with Healthy Aging at the UK Research and Innovations. He leads the program and support UK's government's Aging Society Grand Challenge to ensure that people can enjoy at least 5 healthy extra years, independent years of life by 2035, while narrowing the gap between the richest and the poorest. With that, please welcome Robert, Cynthia, and George.
Thank you, Gene.
Well, thank you so much for joining us today. This is a significant phenomenon that we're seeing across the world, both within the US as well as within the UK. And it's this issue of some of the early data that is showcasing some differences in terms of disparities with regards to the impact of COVID 19. So I thought I'll just start off the conversation by asking all of you, what has been the impact of COVID 19 in your respective countries? Can you describe how that has impacted different groups, and how is the government responding?
Well, shall I lead off and talk a little bit about the UK and give you some background, Gene? So, and from experience, our ethnic mix in the UK is very different from that in the US. We refer to people of Black, Asian, and minority ethnic as a general grouping of this, and call that BAME. And BAME groups make up 14% of the population in England and Wales, probably close to the overall UK. Within that, just over half, 7.5%, are of Asian ethnic groups. 3.3% are from Black ethnic groups, principally from Black Africa and Afro-Caribbean. And then the remainder of just around about 3 mixed multiple ethnic groups or other minorities. But actually, then they're not spread equally, and I think this is going to be interesting later on. So the most ethnically diverse region is London, where 40% of the population of 9 million people are identified with Asian, Black, or mixed or other ethnic groups. Our next major city, Birmingham, has a population of 1 million. Around 30% are of minority ethnic groups. And probably quite similar to London. Typically, over 50% of people from minority groups were born outside the UK. So that sort of gives you a sort of picture of roughly where we are. And I suppose I'd say, just to emphasise the London point, that the current data is indicating that round about 20% of all deaths so far have occurred in London. So we would expect to see some form disproportionate impact. But our National Office for Statistics have just released some early analysis, which says that once you take into account the age of the population and the rate of deaths involving COVID-19, it's roughly twice as high in the most deprived areas of England and Wales as in the least deprived. So we're seeing deprivation generally, not just related to ethnicity there. But actually, there's been some other stuff in the news. So the British Medical Association, which is the UK Doctors Union, reported last Friday that all but one of the 17 doctors who are known to have died after contracting COVID-19 are from Black, Asian and minority ethnic backgrounds. And a study published on Friday, 1st of May by the Institute for Fiscal Studies said that the impacts of the COVID crisis are not uniform across ethnic groups, and aggregating all minorities together misses really important differences. So per capita, hospital deaths are the highest among Black Caribbean population and 3 times those of the white British majority. Some minority groups, including Pakistanis and Black Africans, have seen similar numbers of hospital deaths per capita to the population average, while interesting Bangladeshi fatalities are lower. And you ask sort of how is the government responding? And again, just a reminder, here we have really big differences from the USA. We have a National Health Service to which entitlement is based on residency, not on whether you pay tax or something else like that. We also have a national social welfare system. So in terms of unemployment, we have a system called Universal Credit, which will actually step in and fund families. And that's actually been really important in the early stage of the response for COVID, as we've seen widespread furloughing of the workforce. Clearly, a lot of that will fall to people in hands-on jobs, those that are least able to work from home, and that's been an important part of that. But I'd also mention that actually we've had a longer-term strategy. So, Jean, in the introduction, you mentioned the Aging Society Grand Challenge, part of a much broader UK view that actually, to be healthy as a population, we actually need to be working across the whole population, across the whole life course. And specifically, the work that Cynthia and I do is focused on businesses, including social enterprises, and encouraging them to come in and deliver the services and the products needed to support people to remain healthy. So that's a sort of framework for the response currently in the UK.
No, thank you so much for that, George. I think you bring up some very important points that when you look at some of the differences, it's race, ethnicity, it's income, it's geographic location, and there's a range of factors that's driving some of the differences that we're seeing. So I appreciate that. Cynthia, is there anything that you would like to add to that before we turn to Robert?
I think, it's likely to bring out the fact that this is, the factors that are affecting this are sort of beyond just the genetics, and that there are cultural and socioeconomic. One of the study that George was talking about, they mentioned something around economic vulnerability. So how are people able to provide for their families in the context of a lockdown? And that was disproportionately affecting clearly the sort of relevant groups that we were talking about. So I think that's quite important. The other thing to mention is that there are a number of studies, partly recognizing the multifactorial element to this, that the UK government is funding to help shed some light and perhaps support the gathering of relevant data across all of those multiple groups. So we have a study that is part funded by UK Research and Innovation, and I guess our equivalent of your NIH, ours is called the National Institute of Health Research, and this is looking at investigating some of the emerging evidence that we've talked about in association with ethnicity and COVID incidents and the adverse health outcomes. But also there's a public health element to this. So we're also funding a public health study that's trying to sort of do a rapid review and try and understand from the different ethnic groups in terms of age and gender, can we gather some existing data sets to help create a much more robust data for confirmed cases of COVID-19 across all of those ethnic.
Well, thank you so much, Cynthia. Now we're going to turn it over to Robert. Robert, can you kind of share with us uh, what's going on within the United States as it relates to COVID, and as you heard from George and Cynthia,
Yeah,
the demographic profiles of the population would be helpful.
yeah, absolutely. So in the US, when you look at the racial and ethnic breakdown of the population, you have about 72% are white, about 16% are Hispanic or Latino, about 12% are Black or African American, about 4.8% are Asian, and then the rest of the population includes Native Americans, Alaska Natives, Native Hawaiians, and other Pacific Islanders, and of course, people who are biracial and multiracial. And many people often fit within multiple categories, just given the multiracial composition of the population and of our country. I think two stark data points that are coming out in the US related to COVID 19 are one that specifically the number of deaths in nursing homes is dramatically high. Many states are reporting that anywhere from a third to one half
Mhm.
of deaths taking place in their states are taking place in nursing homes, which tells us both how at risk older people are who live in nursing homes and people with disabilities as well, and also how neglected the sector has been for decades and how all of that is really coming to a head. The other data point that is relevant is that in many cities, the death rates and infection rates are highest among people of color, specifically Black and Latino people. So we're seeing again, I think, the ways in which a long history of neglect, of systematic underfunding, of discrimination, both at the sector level and at the population level, is dramatically impacting the elder care sector, and it's impacting people of color in particular. I work specifically on the issue of direct care workers. These are workers who are home care workers and nursing assistants who provide a range of supports to older people and people with disabilities in a variety of settings in the US. They provide that support in private homes, in nursing homes, in residential care settings. And it's a population that is also marginalized. So the vast majority are women, about 60% are people of color, and about 25% are immigrants. And all of them work low wage jobs, which also makes them poor and low income and especially at risk in this moment. And what we're seeing is that this workforce isn't equipped financially or in other ways to really support all of these older people and people with disabilities who are at severe risk, right? So there's a double way in which discrimination is playing out. And what we're seeing is, as a sector, both their employers and these workers aren't receiving the attention, the recognition, the supplies like masks and sanitizers and gloves, et cetera, and just a general kind of a naming in any kind of relief bills that are coming out. And so I think it's a moment for us to really think about how do we better protect both workers and older people and people with disabilities who are at risk.
I thank you for noting what we're seeing, particularly within long-term care facilities. I think that's another significant data point. And you mentioned both with respects to the vulnerable population in nursing homes and also communities of color. You mentioned several times, Robert, this notion of neglect. That in many cases these are structural issues that have not necessarily been given necessary attention and strategic focus. So it raised a question for me that I would like to pose to all of you. How do we start to alter some of these societal trends and address some of these underlying structural issues that seem to be bringing on a disproportionate impact on vulnerable populations in vulnerable communities?
So maybe if I weighed in there. So I think we've been trying to do this for quite a long time. The question, I think Robert has actually highlighted some really, really interesting points that echo in the UK. And actually, if you look at the experience of Spain and Italy, particularly in their care sector. I think you'll find there are echoes right around much of the developed world. And the answer for me lies in the sort of simple word of population health, that actually hides a really complex set of things that whether it's dressed up as accountable care or something else, it's a fundamental change of mindset required in the way that we deliver care, from actually being able to manage a queue of people who can afford to pay, to directing resources to those most in need, and to produce the best outcomes that you can for whatever resources you have. And quite frankly, that's an approach that means as much in a lesser developed economy in Africa as it does actually in the UK and the US. So we've been trying this, but it's hard. And one of the things that COVID has really shone a light on is that the issue that Robert was talking around about long-term care facilities, and how well we actually respect and reward our care workers. There was a lovely piece on one of our news channels last night of a 91-year-old who was saying that actually overnight she was marvelling. She's in a care facility. She was marvelling that in the last 2 weeks we've changed care workers from being unskilled workers to being key workers. And then she was sort of saying, well, actually now we need to follow that up and do something more with that. But so I come back to your question. What it means is that we've all, in our different guises, faced really tough political choices about trying to make population health work. But now I think is a time where you really can begin to make it work. And it's too early to say exactly what the situation is on deaths actually in care facilities. But it is clear that they've actually borne a much bigger brunt of the pain than actually the hospital sector in the UK, which is coming out of the peak as we speak, having never reached a peak and peak capacity. But we're now revealing that actually the real issue is actually hidden elsewhere, and they're in desperate need of support. So part of the response so far has actually been, there's been a massive increase in capacity to do COVID testing in the UK. So in the last month, it's around a tenfold increase in the capacity. And in the last essentially 10 days, an expanding of those entitled to, and actually moving away from people entering hospital and all the capacity being focused on those entering who were most ill, and beginning to get out to help key workers get back into employment where they were actually self-isolating for all sorts of other reasons, but also actually help people understand what's actually going on with the cared population themselves.
I guess, in terms of looking at some of the structural trends and barriers that you talked about, Jane, I'm reminded that at least within the UK, there's been a number of reviews that have sought to better gather the relevant evidence that helps us understand, I guess, health inequalities more generally across England, notably called the Mammoth Review. So they had a review about 10 years ago, back in 2010, and then followed that up with a subsequent sort of Mammoth 10 years on. And that was really trying to provide a bit more granularity in terms of the recommendations that were made to policymakers to help them realize that the issue of inequality uh, affects not just on the basis of race or ethnicity, but actually it just affects everyone. And that part of what needed to happen was to intervene much earlier on and to start thinking about how some of those benefits might be realized in sort of the decade time. So some of the things they suggested was about trying to ensure that every child has the best start in life and trying to support children and young people and adults to maximize their capabilities and have control of their lives and fair employment and healthy standards for everyone. Uh, but I think what's needed is courage, I guess, from policymakers to be able to set their policies in the context of that evidence and genuinely allow that to help drive the sorts of policies that they are developing. Kind of evidence based approach.
No, I think you're absolutely right, Cynthia, in terms of the importance of having evidence to help drive some of these policy decisions is critically important because evidence can actually help to spur action in a very significant way and reduce some unintended consequences as a result. Robert, anything you would like to add with regards to some of these societal trends and how do we um, start to address these in a very meaningful and intentional way, particularly within the U.S. context?
Yeah, absolutely. I think one of the challenges that I think we face in this country, and one of the reasons that we see higher racial disparities among people of color in particular, is that many people of color are born into communities that lack opportunity in multiple ways, right? They have weaker healthcare infrastructures, there are poorer education systems. There's a way in which structural racism has really shortened the opportunities for people of color, and plays out in later life, and it largely plays out in many ways in people's health and finances. So part of, I think, the approach is to think about how do we better invest financially in the communities of color and people of color in particular. How do we make sure that they have the kinds of supports and services that they need, so that they're able to make it through this moment? I'm curious, in this moment, what is the access that people of color have to good doctors, to good hospitals, to good urgent care clinics, to good nursing homes and home care agencies, et cetera. And I think part of that starts with the investment. As it relates to direct care workers, there are a variety of interventions that would strengthen these workers and ultimately strengthen care for all of us. I mean, direct care workers need higher compensation and more benefits like paid leave and childcare. We need better training standards and training programs for direct care workers. We need advanced roles so that workers can feel like this is a career that they can grow into. And we need just a recognition that these workers are not just essential, but that they should be matched with the kind of resources that it means to be essential. So I think that the more we invest in a primarily women, people of color workforce, I think the stronger of a long-term care system we'll have in the U.S.
No, this is very helpful. I noticed, George, when you were talking, you mentioned the healthcare system that you have, and Cynthia, you alluded to this as well, and to some extent, Robert, you mentioned about the infrastructure that we have in place here in the United States, and I'm wondering, can you say a little bit more about what infrastructure changes we need? Um, to improve on in order to ensure that should there be another pandemic, that our systems, our health systems in particular, um, are more holistic, that looking throughout the continuum of care, um, and more responsive. So I don't know if you have any thoughts on that.
Yes, absolutely. So I think we're going to need a variety of measures to be responsive to both this pandemic and any future health crisis. I mean, I think a number of people in the US and around the world have pointed out that we need better testing systems, better contact tracing approaches. We need kind of treatments and vaccines, and we need the kind of infrastructure that will keep people safe and healthy, even if they become infected. And I think that all of those approaches are important. I think in the context of direct care and nursing homes and home care agencies in the U.S., I think some of the structural investments that we'll need to pay attention to are, our direct care workers who are the primary form of paid support for many older people living in these settings. Are they properly compensated? do they have the right benefits like paid leave and childcare, so that they can afford to be on the job? I think many workers are making the impossible choice of going to work and risking being infected because they're not sure if their employer has the supplies or the protections, or staying home but then collapsing financially because they don't make enough. So how do we bolster their jobs and their compensation and their approach? I think we need more training to really build the pipeline of workers who are going into this sector. Many parts of the country have workforce shortages, and many employers are short on staffing. And I think we're going to need to figure out how to fast track that training, but also not sacrifice the quality of those core competencies that are in those programs, so that workers really do have the skills and the knowledge and the confidence to succeed. And I think we're going to need dedicated funding to certain segments of long-term care. So community organizations that are supporting people of color, immigration supports, supports for LGBT people, et cetera. I mean, these are subsectors of that sector who face an additional challenge. And how do we boost funding support for those communities is going to be a big question for us.
Uh, I just wanted to add that I think also from sort of the UK context, there's clearly a comorbidities factor at play uh, as well. So I think recognizing clearly that certain populations, some of which are the sort of BAME community, are do have higher rates of underlying conditions such as diabetes and heart disease and obesity. And what can we do? I think also from a sort of public health perspective, how do we help drive some of the frameworks to ensure that where there are modifiable risk factors that we can tackle, such as lack of physical activity or nutrition, smoking or excessive alcohol, but also ensuring that we have the right sorts of healthy and sustainable communities for people to live in. So, what are the housing that's available for people to live in? If those don't have the sort of right living standards, then that has a direct impact on health. So, I think there's also a sort of prevention, public health message framework that needs to be developed.
And I'll say this: in the absence of government leadership, and many of you touched on this around the notion of a multi-sectorial approach. In the absence of government leadership itself, be intentional and deliberate in ensuring a healthier longevity and ensuring financial resilience for all. What role does the private sector has to play in addressing some of these issues?
I'll jump in. I guess from the UK and particularly because of the role that George and I have around healthy aging more broadly, we recognise certainly within UK research and innovation that you need a stakeholder approach. You need to have the private sector, the public sector, the charitable sector, the academic sector, all working together in order to ensure that the solutions are comprehensive and that they do genuinely address the challenge of the aging society and healthy aging, which in we know it's a global issue. It isn't just a UK issue or a US issue, and that there's great benefit in working together to be able to address those challenges. So from our perspective, we've worked with partners to try and focus our funding around 7 things where we believe um, we have evidence that shows that they present the greatest opportunity for business, but also actually the greatest opportunities to tackle the market failure and to stimulate innovation in pursuit of that longer, healthier life for all.
Cynthia or George, can you mention what those 7 themes are for our audience? I think that's
Absolutely.
very
Absolutely. So the first one is around sustaining physical activity. The second is maintaining health at work, or as George has broadly termed it, work in later life. Designing for age-friendly homes, managing and creating healthy and active places.
And I just reinforce there that although those are to do with aging, this is there's some really strong COVID response related aspects there that are multi generational
Yeah.
in dimensions. So tackling social isolation, encouraging people of all ages to be physically active. Um, and the reason I think of work in later life is that work as a source of sense of purpose, as a source of social connectedness, and actually long-term financial well-being is really, really important part of our societies. So those are what those themes do, and they are relevant not just to older people, but now particularly in a new COVID world.
Absolutely. I'll share with you that at AARP, we've launched a major initiative with the World Economic Forum and OECD called Living, Learning, and Earning Longer. And it's really designed to foster a multi generational workforce because we know from surveys. And that many companies are managing 4 to 5 generations at any given point in time. And there's a lot of synergy and opportunity for fostering a multi generational workforce. So we've created this learning collaborative that has roughly about 27 major global companies from 7 different countries and roughly about a workforce of over 1.5 million and close to $830 billion worth of revenue when you look at the collective revenue across these global companies, really to foster these dialogues that we've, again, from the data and from a lot of the work that we've seen, that there's a tremendous amount of opportunity, not just for the employees, but also for the employers and the employers who are able to foster that multi-generational workforce, who's able to really invest in their workforce, create policies that are in many cases ageless, will prosper even post COVID-19.
And that's an absolutely great initiative, Gene, and we take our hat off to you for that.
Absolutely. Absolutely.
Robert, in terms of some of the work that you've been doing and some of the stakeholder and coalition building work that you've been doing, in the absence of a federal response or a government response in the U.S., how are you seeing some of these other sectors step up and really try to address these issues in a very meaningful way?
Yeah, I think there is quite a bit of innovation that's happening at the industry level and among providers, both on the direct care workforce front and also in the broader long-term care and aging services front. And in the aging services world, there's been a really important conversation that's really heightened, I think, in the last few weeks, which is how do we ration care in this country, anywhere from if you have a set number of ventilators, but too many people who need them, what's the best approach for that? Or how do we ration testing? How do we ration supplies, etc.? And unfortunately, for a while, that conversation was really focused on limiting access to treatment and supports to older people, because it was presumed that if you're older, you somehow should sacrifice yourself in this kind of ageist idea, right? And I think the aging services world has really pushed that conversation and said, look, we need a broader framework. Older people should not be punished for their age, and care needs to reach them and it needs to reach their settings. And so we're seeing, I think, a lot of conversation on that front. On the direct care workforce front, I think we're seeing, and we'll be seeing more of this, more online training approaches that are able to train workers from a distance and or are tested in such a way that they don't lose the skills and the knowledge, that workers still acquire the skills and the knowledge that are needed. It shouldn't replace an in-person approach for a variety of reasons, but I think in this moment, online training is really what's going to be needed to keep people safe and to reach as many people as possible. And we're going to see some good innovation in that front.
Right.
Yeah,
Well,
so I was just going to add, we completely agree with that. So we know, and there is direct evidence that demonstrates that poor workplaces contribute to ill health, both physically and mentally, right? So
Mm.
it's unfortunate, really, that the workplace is some of the most underexploited sites, as far as we're concerned, to help people manage their health and enable them to age well, from that
Mhm.
context. No, absolutely.
In the interest of time, I'm just going to pose you one last question, and would love your top two or three ideas to this, or suggestions, and that is, what game changers could drastically shrink inequalities across racial, ethnic, income groups, geographics. I'm using inequalities in a very broad sense here, between populations in the next 10 years. So we kicked off 2020, and boy, did we kick off 2020 with a bang, right? Um, so, let's say in 2030, what would success look like for us?
So why don't I kick off? Your question's a tough one, actually. But what's really interesting about it is that if you put the 2030 timeframe on, you actually realise that the things that we've been thinking about all along are still really important. And COVID will go. It will have had a catalytic effect on doing some things, but fundamentally we have problems um, in all our societies: aging populations, inequality. We will still have some form of climate change challenge, etc. Um, but I think there's some cause for optimism. Certainly in the UK, I see a shift in attitudes. Our younger generations are different and much more aware and accepting of diversity. But I'd say that's no cause for complacency. Um, I said earlier that I thought population health is the approach that will drive better health for all. Um, and again, this is hard, and it's not just about health. The governments that are really successful are building healthcare into policies right across government: education, sports and leisure, transport, employment, and so much more. Um, so that's sort of to say there's no magic bullet. But do I think I see some specific hope around particularly ethnic communities? And one area, for instance, that I think is in medical research. I think there's a growing realization that so much of our medical research is done on fit, younger populations, mainly of European general ethnicity and extraction. The UK is setting up the world's largest biobank and population study, aiming to recruit 1 million people for uh, genetic and biomedical research into a database. It's called Accelerating the Detection of Disease. A major part of that is to address the inbuilt inequalities that a lot of our work currently does. And I would really hope that in 10 years' time, we would start to see some really genuine moves around uh, a better understanding of the needs of minority populations built into our approach to health and care.
Cynthia?
Well, I'll add to George's list. I'm not sure if I have two, but I definitely have one. And my one is around digital inclusion. I think as we become more digitally included, that should ensure that people are able to access the sorts of information and data that they require to live lives that are not increasing loneliness and self-isolation, or making it less likely that they will be able to access the sorts of jobs and education, and potentially access to information from governments, which we know increasingly is done online, right? So some of that also then puts them in a position where they feel that their voice isn't heard. I think as we become more digitally inclusive, it should ensure sort of amelioration of the racial inequalities as well as the health inequalities.
Robert?
I would focus on three specific strategies. One is I think it would be important for our long-term care system and probably our full country to adopt an explicit racial equity lens, a racial and gender equity lens, where providers and government leaders are collecting data on disparities among people of color, among women and other populations, and are creating policy interventions and programs that explicitly address those disparities and create more opportunity for people of color, for women across the board, et cetera. And there are a variety of toolkits that exist out in the field that make that work practical. The second is I would completely transform the direct care job and make it a higher paying job, provide benefits, better training, all those kinds of supports that would make the job more appealing to workers and would also improve care for people. And third is I would create a sound and humane immigration policy, a support that would support immigrants who are not only working in long-term care and receiving those supports, but are actually essential to the entire economy. How do we address the needs and the aspirations of immigrants, and how do we create a community and a country that really supports all of us, regardless of where we are?
Well, thank you all for your time today, for sharing your perspective and your insights and your expertise. Before we wrap up, is there any thing else that you'd like to share with the audience today in light of our conversation that you think that they need to know?
Well, I'll kick off. So I guess I believe health inequalities are not inevitable, and I don't. I think we can make significant inroads into reducing it, and there is possible to avoid health inequalities. And actually, avoid inequalities are just unfair. And whilst every society we accept will have some level of economic and social inequality, what we can envisage and work towards is a society that creates the conditions for everyone to be able to lead lives that have reason to value.
Wow. Thank you so much for that, Cynthia. I see George and Robert shaking their heads, and I couldn't agree more with that. In closing, I want to thank all that of you who participated on our, today through Ideagen Summit. As we heard from our distinguished panelists, health and economic outcomes have historically been tied to an accumulation of opportunity, and the highest bidders benefited tremendously. However, there are two divergent paths ahead for us. On one, we can continue to go down the path uh, under the current systems that yield some of the inequities that we spoke about today and that harm some of the most vulnerable among us. Or we can take a different path and imagine an entirely new future, as Cynthia articulated, that embodies the resiliency and the interconnectivity that we all have among us. A route that affirms our sense of unity and the notion that we are much stronger together than we can ever be in isolation. Now is the time, frankly, to take that second path. During these difficult days, ARP is actively engaged in the response to COVID 19, the outbreak itself. And we're working hard, not just for our members across the country, but also their families and the broader community. We're fostering global conversations to look at resources and tools to really help us reimagine a much brighter, resilient future. Again, I want to thank our panelists today for your time, for your expertise, and have a wonderful day.
Gene, thank you very much. It's a great panel.
Thank you.
Yes, thank you.
Thank you. All right.